Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. My guest today is Dr. Reshma Jagsi, who is the Newman Family Professor and Deputy Chair in the Department of Radiation Oncology and the Director of the Center for Bioethics and Social Sciences in Medicine at the University of Michigan. She has an expertise in radiation and management of breast cancer, while also dedicating a huge amount of research time and teaching effort to gender equity and success in academic medicine. Reshma, thanks so much for taking the time to talk with me today.
Thanks for having me.
I'd like to start with a bit on the origin story of our superheroes and a bit on how you grew up, where you grew up. Was that in Texas?
It was in Texas, but it was a little bit of a circuitous route to get there. So my parents actually both grew up in East Africa, in Tanzania, in two totally different communities. My mother was a Muslim, my father was Hindu, and those two communities didn't really interact all that much. They were of Indian origin, but because of the British Commonwealth, there were a number of Indians who had moved to Tanzania, and both of them had been born in Dar es Salaam and grew up there. My mother, who was an artifact of an era when little girls didn't go to school for all that long. They certainly didn't study math or science beyond the 6th grade, somehow ended up being an intellectual and convinced her parents to allow her to apply for a scholarship to study abroad in the United States. And she came in the heyday of the 1960s, joined a peace caravan, attended the University of Wisconsin-Madison, and got her bachelor's and her master's degrees in English and education. And so she went back and was really planning to immigrate permanently to Canada, again, because of that British Commonwealth tie, but she very much had liked North America, and her parents had passed away while she was studying abroad. And so she went to go get her leaving paperwork and went to go see a physician who was in a 2-doc practice, and it was the senior partner of my dad, who was himself a family physician. And apparently the story goes that my dad knocked on the exam room door just a few times too many, needing, an instrument that was in there or needing some swabs or needing something else. And about the 3rd time he knocked, his partner said, "Would you like an introduction to my patient, Dr. Jagsi?" And that's how my parents met. And so my mother actually ended up leaving. She did end up moving to Canada before my father left. My father remained behind for several more months. And then he says that same senior partner came to work one day and showed him the newspaper headline, which said, "Physicians being nationalized." And what that meant was that the government was going to tell physicians what patient populations they served, where they had to practice, and completely take over control of their lives. And the senior partner said to my dad, "If I were a younger man, I would think about taking a vacation right around now." And my dad said he knew exactly what that meant. And so he took his diploma down off the wall that day. He rolled it up into a newspaper. He says he wouldn't fold it. He couldn't bring himself to fold his medical school diploma. So he rolled it up in the newspaper like he was going to read the newspaper on the airplane. And he went home and he packed 5 shirts and 5 British pounds cash. And he took off his watch and took nothing of value. And he went to the airport, and the guard said to him, "You do realize that you're not allowed to leave the country anymore. Doctors are now nationalized." And he said, "Absolutely, but I had a pre-planned vacation to England, and I'm only going for 5 days." And they looked in his bag and they saw the 5 shirts and they saw that he had $5, and they said, "This guy's not going to last long. Go enjoy your vacation, doctor." And he never went back. He ended up going to Canada, proposing to my mom. They raised me for the first 4 years of my life in England, and then we eventually ended up in Texas. So a long story for me to get to grow up in Central Texas.
That's an amazing story, by the way. I mean, I really have to give your dad credit for being able to turn on a dime like that, I think that takes a lot of courage to leave all you know and head into the unknown with so little.
Absolutely. Absolutely. And so being the kid of those two people, I think explains a lot about the more unusual interests that I've had in medicine and the strong sense of duty I've had to society and pursuing issues of equity and social justice. Because I think it's really important for us as physicians to be engaged at every level to ensure that our societies remain stable and that we represent the voices of our patients.
I know there are many people of Indian descent in Texas or in the South. What was it like for you? Did you have much of an Indian identity, or did you feel like an outsider at all there?
So it was a really unusual opportunity to observe race relations in the United States because I really didn't have many Indian or East Asian kids in my class. There were a couple of us in a largely white school, and we were different, but we weren't Black. So we weren't discriminated against in the same way as American Blacks experienced. And we were, I think, in a unique position to observe the unusual race dynamics that have developed in this country. So it was a unique situation.
But did you feel much of an Indian identity, or did you just feel like an American?
Yeah, so that's a great question. I felt very much like an American. And I think part of that is my unusual upbringing by a mixed religion couple, right? It's not that common for a Muslim woman to marry a Hindu man. Like that's not a common thing. And so they were already outsiders in that sense. And I developed a very, very strong sense of duty to country. And I have always strongly self-identified as American. And of course, that is something, growing up in Texas, there's a lot of patriotism. I embrace that whole hog. In fact, this is funny that you brought this up because you probably have no idea, but it was written about me when I was in college. My college roommates convinced me to apply for Glamour magazine's top 10 college women.
Oh, I know that. You won top 10 in 1994, as I recall.
Yeah. So spoiler alert, it was not based on what I looked like, but they thought I had some promise as a college woman. And so they did little stories about us. And I believe they ended up focusing on the fact that I had decorated my dorm room in red, white, and blue. And my best friend in the world, who's still my best friend today, she's a pediatrician in Boston. She was my first college roommate. And she was a daughter of Italian immigrants who had grown up in the Boston area. And she was fascinated by this, Indian American immigrant who came to college and decorated her whole half of the dorm room. I decorated my whole half of the dorm room in red, white, and blue and had all of this great antique Americana. And I studied government. My undergraduate concentration was government. I was a government major, and I was focused on American government, specifically in constitutional law. I very much have always identified as American. And I think that the beauty of the immigrant experience is that we are able to assimilate and love this country and contribute. And so I've always felt such a strong sense of patriotism.
So I do want to explore more on your focus on government, which is not extremely common for folks going into medicine, but you majored in government, excelled in that, served as a fellow in the Center for Ethics at Harvard, pursued a doctorate in social policy at Oxford University as a Marshall Scholar, and you also worked as a White House intern in the mid-90s focusing on health policy.
It's true.
How did this integrate with your medical training at Harvard Medical School? Did you have a vision of what you wanted to do? And did it look like what you do now? Or were you always planning to just go into clinical medicine?
So that's a great question. So I actually did a stint as a volunteer during the summers when I was in high school. It used to be you could start volunteering when you were 13 at the VA Medical Center in town. And I started volunteering there every summer. And it was sort of an outgrowth of the patriotic impulse that I wanted to go and volunteer with veterans. And it turned out it was a medical center as well. And so I got to see the wonderful relationships that physicians had with their patients. And in fact, one summer, my father was a physician at the VA. One summer, I actually got to work as a nurse's aide assistant on his floor. And I got to see the relationships that he had with his patients and the stories that his patients would tell me because they saw me as an extension of him. And I saw the tremendous privilege that physicians have to interact with people at difficult moments in their lives and to make a difference. And I became very interested in the promotion of health. And when I got to college, I became acutely aware of the social determinants of health, right? So I had moved from bootstrap Central, right? Central Texas, I was a Republican. I campaigned in high school for the Republican candidate for Congress. I went on later in college to actually work for his Democratic opponent after I pointed out to him that I had campaigned against him, and he said he wouldn't hold it against me. But when I got to college, I was surrounded by visible reminders of the fact that it's not just hard work and diligence that leads to success in this country. I was confronted by Harvard Square and noticed that the homeless people who were there were clearly often afflicted with mental illness and were not simply deficient in the desire to pull themselves up by those bootstraps. And it was very different from the upbringing that I had in Texas, in that very comfortable upper middle class, daughter of an immigrant who came with nothing, but did come with that education, right? That medical school diploma was incredibly valuable. And my dad was able to build a secure middle class upbringing for me. And so I went from that comfortable environment where people didn't interact with individuals who were coming from vastly different social backgrounds, right? You got into your nice air-conditioned car and you drove to your nice air-conditioned school and you went to the nice air-conditioned shopping mall and you interacted with people who were like you. And it was easy to assume that those who were on the dole because they were lazy and they weren't working as hard. And when I came to university and I was starkly confronted by the reality that that's not the case, I became very committed to addressing the social determinants of health. And my next few volunteer experiences, again, sort of stemming from this desire to serve society that my parents inculcated in me, were actually in a public interest law firm working with clients who were being evicted. So it was basically the prevention of homelessness. It was clients who were facing homelessness because they were being evicted from their homes at Greater Boston Legal Services, and then also teaching civics to high school students in high school classrooms. And those experiences really helped illustrate for me how much of health is socially determined. And so that's why I chose to study government, why I chose to study social policy, why I've been so engaged in these issues, is that I fundamentally, like many of us in medicine, don't just want to deliver medical care. I want to improve the health of my community.
Did you think along the way that maybe the best path to having a broader impact is to not be in a clinical role and focus on policy and law?
Yeah, absolutely. In fact, that's what I thought when I went to go work at Greater Boston Legal Services. I thought, oh gosh, I'll go to law school, right? I'm an Indian kid. I wasn't going to go off and have a wonderful music career, even though I played the piano. I was going to do something that was a profession, right? That's a classic immigrant story. But I did think that I would do something different from medicine. My father, a very humble person, used to say to me, I think he's probably the only Indian dad who genuinely did not want his daughter to become a doctor. He really believed in me. And he said to me, "You're so smart. You could do so much for the world. Don't just become a doctor. People like me can become a doctor. You could do so much more if you did something broader. Don't just become a doctor." And I have to say that all I kept seeing as I went through my experience at Greater Boston Legal Services and my teaching in the classrooms was that I couldn't think of a profession that had a more profound impact on individuals than medicine. And I remembered those relationships that he had with his patients. And in the end, I decided that in my day-to-day career, what would bring me the greatest satisfaction would be always to feel that connection to individuals, to always be grounded in their stories and their lived experiences. I mean, that's why the best writers we've had have often been physicians. That's why some of the best insights we get are from physicians, because physicians we're so fortunate to have that opportunity to observe the rich lived experiences of other members of our society and to tell those stories. And so I decided I really did want to practice clinical medicine, but then I also couldn't let go of my desire to contribute to social justice and improving social determinants of health. So I kind of decided to try to do both, and it's certainly kept things interesting.
I'll say, it's interesting. I think that clinical medicine offers that immediate feedback that's almost indulgent in terms of getting that gratification that you don't necessarily get on a daily scale when you are working in a lab and potentially contributing to a population or policy. You may not see the people who are the beneficiaries, even when there are a lot of them.
Exactly. I think that's exactly right. So it's this issue of statistical lives. It is really nice to be able to tie to individual experiences. And you're absolutely right. I view it as an indulgence. I absolutely love my job. I love the day and a half a week that I spend in clinic with patients with breast cancer and getting to interact with them on that personal human level. It brings me such inspiration and it nourishes me. And I feel so grateful to have that privilege. And I know my dad actually really did enjoy that too. And I think that in the end, it actually brought him a lot of pleasure to see that I got to have that experience. And I think it also made him proud that I try at least to bring those insights to inform policy at a broader level as well.
Well, I think you've done well integrating those two aspects into a career that is very rich, maybe too much for one person to manage, but certainly you're capitalizing on what he hoped for you to achieve.
I hope so.
Your husband is a law professor, a lawyer. Is that correct?
That's
and
correct.
You met in college?
We did. We were nerds in love in the Harvard University marching band. I'm pretty sure there's actually no nerdier meet cute than meeting in the Harvard University band.
Right. I was in the Princeton band and I played coconuts in it. So I hear you.
Yeah.
So I would imagine there was never a question that you would both have major commitments to your high-powered careers. And you've written about the struggles of women finding a time for having children, but you've had a couple, I believe. What was your timing? And what would you recommend to women who are still in the midst of training and trying to map out a time when having children will be most feasible or at least less challenging while negotiating the trajectory of a career in medicine?
That's a great question. I will not hold myself out as an exemplar. I actually think from talking to many, many women, there's no perfect time. And the best advice I ever got was have your babies when you're ready to have babies, because there's never going to be a perfect time to do it, but don't wait too long. And I think that some of my research has really emphasized that there's a degree of surprise that we as physicians have when we discover that we're infertile. And you might say, how could that possibly be the case? We were trained in medical school. We know the timing of fertility in women, and we shouldn't be surprised. And yet many women end up having struggles and challenges that I would not wish upon anyone. I was very fortunate. We ended up having optimal timing, if there ever is such, in that I was able to get pregnant when I intended to get pregnant, which was right before the research year of my residency training program, which was a perfect time to experience the first year of a baby's life and in a bit more of a flexible environment. It was during, research time, which is a little bit more flexible to scheduling. And then I had my second child a couple of years after I began my faculty position. Some people say it's not ideal to have young children when you are trying to get tenure, but I think that it's also not that easy to have children when you're a clinical resident. It's not that easy to have children when you're a medical student. And quite honestly, it may be too late to have children after you do have tenure. So I think you have to have them when you have them, and you have to be as creative as you can be in trying to structure things so that you have as much help as possible. I've certainly not done this on my own. I once told a story to my daughter who was asking me in the bathroom of the racket club at the Ann Arbor Racket Club. This is the club to which many, many faculty belong. It's got a swimming pool and you take your kids there and they swim in the swimming pool. And we were in the locker room and there was a sign up on the locker room wall that said, boys under the age of 4 are allowed in the women's locker room. And my daughter looked at me and said, why is that? And I looked back at her and I said, well, honey, there's some people who believe that just because women are the ones who bear children, that women are the ones who are better at taking care of children. And so this is to facilitate women being able to take care of their little baby boys. And she looked at me and she waggled her little finger at me. And I think she was all of about 8 years old. And she said, that's not happening. And I said, well, honey, it won't happen for you because all you need to do is marry someone like Dad who does half the work. And she looked back at me, and by this time, the whole locker room is silent, listening to this conversation going on between mother and daughter. And she looks back at me and she says, oh, no, Mom, Dad does way more than half the work. So I think you have to be fortunate in, finding a partner who does contribute, and then also outsourcing everything that you don't enjoy. So if you enjoy feeding your baby, absolutely feed your baby. But if giving the baby the 8th bottle of the day is no longer enjoyable to you, don't feel like you have to feed your baby every single bottle, or that if you like nursing, that's great. If you can't nurse, or if you can't nurse exclusively, we shouldn't hold it against you. You should, certainly try to do what you believe is best for your baby. But I think we have such high expectations of women doing everything all by themselves without asking for help. And I think that's unrealistic.
Yeah, I am impressed that things have worked out as well as they seem to have for you with your kids and your husband doing as much as he's doing, especially with his own significant career obligations, I presume.
Yes. I mean, it's interesting. Someone once said when they saw my son and my husband together, and my son is very, very sweet and very, very, he's chatty and fun, and he's fun to be around. And so is my husband. And someone said to me, your son is just absolutely a duplicate of your husband, really type B, laid back. And it made me laugh because, of course, if you said to anyone who's in my husband's very high-powered field that my husband is in any way type B, that's just not true. But he manages to seem type B, and I think we have this expectation that no one could have a 2 type A partner couple, so he must be type B by definition. But no, he's actually an international bankruptcy professor, and so spends a lot of time working on model laws that govern cross-border insolvency. He travels to the UN, so we try to travel in ways that don't leave the kids without both of us. They've pointed out to us that they find it okay when mom or dad is away for work, but they don't like it when both of us are away for work at the same time. So we try to work it out so that we're actually around at the same time, at least some of the time, and at least not both away very often.
Mm-hmm. So among all of the things you do, you also served as a troop leader of your daughter's Girl Scout troop. Given how much you've focused on gender identity, I imagine this was a very thoughtful decision of what the organization promotes and how you've raised your own daughter. Can you talk about what the Girl Scouts has meant to you?
Yeah, that's a great question. So I myself was a Girl Scout when I was growing up. And, Girl Scouts is an organization that fundamentally seeks to empower girls, regardless of their background, to engage in any activities that they can to help one another. And so it is that bond of sisterhood and that empowerment and the skills that they provide. I mean, the badges they earn are in just about anything you can imagine, and, range from activities in STEM, so that, promotion of girls going into fields like our own, to, entrepreneurship and financial literacy. Selling those cookies actually requires a lot of organizational leadership and planning. They came together and thought about, for example, how they would spend the proceeds of their cookie earnings. And I'm very proud of the girls in our Girl Scout troop who came together and decided that they would use a portion of the proceeds to support an organization that provided bicycles to girls in the developing world, and made it possible for them to engage in their societies and attend school and take on work and become independent. And so I think Girl Scouts is a really wonderful girl-led, woman-led organization. And so it was a neat opportunity for me to get to spend some quality time with my daughter and her friends and the other women in my community, and also I think equip my own daughter with some skills she'll use for life.
That's terrific. Now, you trained largely in Boston and Oxford. Before your residency, you spent that intern year in Hawaii, which seems like a big curveball, before then later going to Mass General and the Harvard residency program for radiation oncology. What led you to Hawaii, and how was that year for you?
So it was Hawaii. So really, honestly, we talked about this. My husband and I talked about this, and he said, "Why don't we do something adventuresome for that 1 year?" I mean, it is sort of a unique thing when you train in a specialty like radiation oncology that you match into your specialty residency at the same time that you match into that preliminary year. And it turns out that actually serendipitously, because it's not like I planned it this way, serendipitously, Hawaii was a brilliant program. It was actually a really intensive community-based program. They do have a university hospital at Queens Medical Center, but just some of the most seriously ill patients that I've ever encountered in my careers, because they're not as segregated into multiple specialty ICUs being run by fellows, and rather the interns and the residents actually have a real opportunity to engage in complex decision making in really challenging patient cases from the get-go, with really close and wonderful supervision and teaching from the faculty there. They're in-house intensivists who are there, who very much love to teach. And so I really became a doctor that year. I learned so much from that program. But again, why did I go? I went because it was Hawaii. I think that's why most people go.
Well, yeah, I understand that. My wife lived in Honolulu for 14 years before we ended up connecting. Yeah, it's a great place for us to go visit family, let me tell you.
Yeah, it's such an interesting culture and environment. You learn so much by being there. It was like studying abroad. It was like going to England. I mean, in some ways, when I went to England, I found less culture shock than when I went to Hawaii. So it was definitely something that helped me grow in many ways.
Yeah, it was interesting. When I spent 1 year in England, which was at Cambridge, I was looking for an immersive experience that didn't have too many Americans. And I would have to say it was a little isolating. There were very few Americans there while I was there. And you ended up in a social hole in every dinner conversation as the apologist for U.S. policy, as if you were setting it. And, it was really challenging. And it was about the only place I ever encountered anti-Semitism, not ruthless, horrible stuff, but just comments here and there. And I found it just a more challenging experience than I would have expected. I don't know what it was like for you as an American at Oxford, where there were way, way more Americans.
Way more Americans. Yeah, so it's a great question. So when I was selected to be a Marshall Scholar, they had a reception in Boston at the embassy. And one of the people who was on the selection committee came up to me. And this is like a champagne reception. I'm standing there with my little champagne flute. And this person comes up to me and says, I was actually on the national selection committee that approved your application. And I'm thinking this conversation's going to go well because, I got the scholarship, right? And he says to me, I was actually the vocal opponent of your application because I see that you're applying 2 years into medical school. And I hear that you have this tremendous commitment to social justice and you want to study social policy, but I don't see why you wouldn't just do that here in the United States and, do a master's at the Kennedy School and move on and become a doctor, because clearly you're passionate about becoming a doctor. And what I fear is that what you're going to do is you're going to go to Oxford and you're going to actually do a 1-year degree, that you're going to convert what you're proposing as a 2-year degree into a 1-year degree. And the Marshall Scholarship is intentionally a 2-year program because it takes a year before you even crack through the shell of the Brits. And the purpose is to build lifelong relationships between Americans and Brits, and that to really form bonds with people who are British, you won't be able to do that in the first year. That won't come until your second year. And I said, oh, no, I'm fully intending to do what I proposed and stay for the 2 years. He said, yeah. He's like, you got the scholarship. It's fine. Everybody else believed you. It's like, I'm skeptical. And all I will leave you with is a plea that you at least consider staying for that second year. And I did stay for the 2 years. In fact, I stayed for a third and got my doctorate. But I took his advice to heart, and he was absolutely right. So there were way more Americans at Oxford than at Cambridge. And certainly the first year, we spent a lot of time together, the expat community. And it was Americans and a few, expats from other countries mixed in, but we had very few British friends. And it wasn't until my second year there that I made close friendships with several British citizens with whom I continue to be close friends. And so I am grateful that I had that opportunity for that second year, as well as the opportunity for that first year where it was easy to ease into that social circumstance because we did have a little pack. We had a gang. And so by the second year, I felt comfortable. So yeah, it was a magical experience.
And I think you're exactly right. I think one of the challenges I had was that the Fulbright that I was on was a 1-year program. Now, I had an opportunity for at least a second year, but my fiance, eventually ex-wife now, did not want to stay in the UK. And so we went to Boston and I started medical school. But I think that 1 year is a very challenging amount of time. It's enough to get started, but really not fully commit to or have the opportunity to develop deep relationships. And really, by the time you're even thinking about getting settled in, you're packing up to leave. So I think that was a real challenge. Yeah.
Yeah. Agreed.
What led you into radiation oncology as a specialty?
So that was another bit of serendipity. I think everyone in radiation oncology has a serendipity story. So mine was that I was absolutely going to become a neurologist. After my preclinical years, I really liked the thoughtful anatomic localization and sort of the master clinicians who could tell you where the lesion was without even looking at the MRI scan. And so the way I sequenced my clinical years was I actually did my neuro rotation before I went to England. So I went technically between my second and third years of medical school, but I actually did 3 months of rotations before I left. And during my neurology rotation, the resident on the service, who, by the way, is actually really famous and has a TED Talk that I ended up watching on an airplane the other day, Gottfried Schlaug, who studies music in the brain. But he was trained in Germany and he was redoing his residency in the US, and he was the resident with whom I was paired. And he said to me at the end of my rotation, he pointed actually to a radiation oncologist who was a resident who was in the cafeteria. And he pointed her out to me and he said, "So I've been very supportive of your enthusiasm for neurology throughout your clerkship because it's been really good. It's great that you've wanted to dictate every single note and give every single presentation and that you think this is what you want to do with your life. And it's been wonderful having you on service. But I feel like I would be derelict in my duty to teach you if I didn't point out that there's a field out there that might actually be even better suited to what you want to do. And I wish I had known about it. And it's a field called radiation oncology. And it also has the benefits of getting to harness your knowledge of anatomy and clinical reasoning. But when you have raised at the end of certain cases, so now we've discovered what the problem is, how are we going to treat this? What are our satisfying targeted interventions? How are we going to save that person's function? And we've had often disappointing responses for you about how we might be able to prevent a subsequent event, but how the event that has occurred is not now reversible. What is so wonderful about what this woman does, it was Akila Viswanathan, actually, who's now a famous gynecologic radiation oncologist, but she was a resident at the time. He said what Akila gets to do is she actually gets to reverse things. She gets to cure people. She gets that benefit of intervening. And he said, I would just encourage you, introduce yourself to Akila, do a rotation in that before you decide that neurology is what you're going to do. And so that good advice led me to it.
I mean, it's so funny because I was also a neuroscience major. I focused on neuroscience and physiologic psychology at Princeton. And then that year that I spent in England was in a lab working on neuroscience. I did a year as a Howard Hughes Fellow at Mass General in the neurology department.
Yeah.
And I was really thinking about the same thing. But then I found that clinically, it was basically too much diagnose and adios, which is essentially what you were saying, that there just wasn't enough to be done. And even though I was impressed by the thought process, it also seemed a lot like, well, you figure all this out clinically, and then you go do the MRI, and it's like checking the result in the back of the book of your math test, your math problems. But it's just been fortunate also that the field of oncology has had so many amazing developments over the last couple of decades.
Absolutely. And we shouldn't dissuade anyone who's listening from a career in neurology, right? Because I think there are many more things that can be done now than could be done when we were training. But
absolutely,
but oncology has been such a wonderful gift. I do feel very fortunate to be in this field.
Well, and I think that there's different priorities for different people. I think that the brain is a remarkably fascinating field of study.
But I think what I like about radiation oncology is that we treat the whole human being over the entire lifespan, right? We treat children, we treat older adults, we treat for cure, we treat for palliation, we treat every body site. We do complex physics calculations. We understand radiation biology. We also, have to do our diligence in terms of knowing the clinical trials data in every field of oncology well, because we're part of a multidisciplinary team. So we know the clinical trials. And of course, we focus on translation of clinical trials results into practice. And so I feel like we have this tremendous opportunity in radiation oncology to be physicians in the broadest sense. And that I very much love.
Yeah, that sounds hard. I don't know. There's a reason why many of us focus in one or two narrow areas. So I think that's...
Yeah, well...
And I don't think I have the physics ability anyway, so...
Can I jump in there? Because I think there's a misconception about the level of physics ability. So we like to say that we do complex physics, but quite honestly, we also do work closely with PhD medical physicists who are on faculty with us. And so for anyone who's thinking about not going to radiation oncology because they don't think they're good at physics, everybody took the physics portion of the MCATs and got into medical school. And the level of physics you need to be able to do is perfectly attainable and achievable by someone who did fine on the physics section of the MCAT. So I don't think that should be a barrier. And I hate that we lose people because of that, because we want well-rounded people. We don't need physicists. We have physicists. We actually have PhD medical physicists who work with us.
Very good. I was being glib about that, but...
I know, and I'm going to still try to recruit you into radiation oncology. There's always...
I did a great elective at the Joint Center for Radiation Therapy and thought about it very seriously. And I wanted to ask also, was the potentially lifestyle sparing field of radiation oncology part of the decision? Did you have any sense that that would make it a more attractive area to go into? And is that something that when you talk with medical students who may be figuring out what to do next, you factor in as a leading feature?
So I don't tend to emphasize that with students that we're recruiting in, because in the end, I think we shouldn't be focused on the short-term period of training as much as we focus on the long-term period of career that follows. And I think that in terms of long-term period of career that follows, I'm not actually convinced that radiation oncology differs that dramatically in terms of lifestyle from many, many other medical specialties. So I think that people should choose their medical specialty based on what they're going to be doing for the 30 years that follow training, rather than what is going to happen in the relatively brief period of time that they are trainees. That said, did having a research year during training and having call taken a week at a time with more reasonable work hours make it more feasible for me to have had one child when I was in that research year and then finishing the last clinical year? Absolutely. And would I probably have had to delay childbearing, or felt that I had to delay childbearing? This was before ACGME duty hours limits. I think if I had been in another specialty, it might have had implications for those kinds of decisions. But when I think about what people should be choosing their specialty based on, it should be based on a fundamental excitement about getting to be part of a field for one's lifetime, and not a somewhat myopic focus on what the next few years might entail.
Yeah, I was really far more thinking about the longitudinal view, but I think many of us who are medical oncologists have some envy of what seems to us a more favorable schedule for many of our radiation oncology colleagues.
No, that's fair. That's fair.
That may just be the grass is always greener.
I think that's true, because when I look at my academic colleagues here, it's actually harder for us sometimes in radiation oncology to create a physician scientist job that protects sufficient time for research, just because we have patients who are in the department every day who are being treated. And so, one has to have a certain amount of time seeing one's on treatment patients. And so it actually, there is no such thing as a half day a week of clinic in radiation oncology. It just doesn't work. So it is interesting. So some of our medical oncology colleagues end up actually having, I think, quote unquote, better lifestyles, if less clinical work is a better lifestyle. But I'll tell you, nobody has a better lifestyle in terms of getting to interact with patients and have that longitudinal relationship than radiation oncologists. And that's what I think people should be selecting in for, is that opportunity to have a patient on treatment for several weeks with you, who's coming in literally every day, who starts to think of you as their doctor because you were there for them at a really difficult time in their disease trajectory. That's what should draw people to our field, I think.
We'll continue our discussion with Dr. Reshma Jagsi in the next episode. Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.